So welcome everyone who is getting on line at this point to the Right Care Initiative. We're certainly enthusiastic about the program today. I think we have a very excellent program that you'll be enjoying as well as learning from. So we have a few minutes before we start. We'll start roughly at 4 p.m. And the program is being recorded, and you can submit questions using the Q&A tab at the bottom or the top of your screen, depending on what format that you're using for it. And if you want to test out your Q&A question, you can list on there, and we'll have on the chat box things that you would be grateful for today. Unfortunately for the state of California, we're involved in a firestorm currently at this point in time, and as well as a pandemic. But certainly we are grateful for anything that is positive, and if you'd like to list that, please do. We'll take a 2-minute pause here while we get ready for the program, but thank you for joining us, and we'll be starting the program right about 4 p.m.
Where's your picture, Scott? What is that background?
That is a place called Bonaire, which is one of the ABC islands off the coast of Venezuela.
Wow.
Aruba, Bonaire, Curacao. And about every second or third year, I get to teach a diving medicine course there.
That's beautiful.
Yeah, so it helps remind me that there's another world out there we'll get back to one day.
Hey, Scott, just to give you the heads up, I'm going to call you out at the end when we talk about the next steps and the toolkit, in case you want to say a few words.
Sure.
Okay.
Thanks, Cindy.
Welcome, Dr. Brooks. Glad to see you've joined us. You are muted, and I think that Bill is about to start. It's 4 o'clock, and let's, and I see Marnie's with us. Hi, Marnie.
Good afternoon.
And it's a good thing we're recording this session because a lot of people are under evacuation orders right now, dealing with the firestorms in various regions. And I am going to request that our statewide chairman, Dr. Bill Baumer, lead us off with showing us through the agenda, et cetera. Thank you, Bill, so much.
Well, thank you everyone for joining us today. In the midst of these unfortunately serious situations of pandemic, as well as the firestorms in California. Before we start, we'll take a minute or a moment of silence just for those who unfortunately have lost their lives in the firestorms in California, as well as the pandemic in California today, as well as the usual cardiovascular disease, those deaths. We certainly miss or will miss those individuals. Some of our colleagues today that I have talked to have actually just evacuated their hospital, and many of them have lost their homes in California wildfires. So our thoughts and prayers go out to those individuals. The program that we have today is very interesting. And if I could have the next slide, Megan. We've wanted to at least acknowledge the support that we have received, the very valuable support from the sponsors shown here. These sponsors are vital to the program that we have put out for the Right Care Initiative. Without them, we could not be presenting this information today. We'd like to highlight each of them, but especially today, Blue Shield of California, which is actually responsible largely for the program for the Bay Area that was recently started within the last 2 years. They in fact challenged us to do that and also supported us for that. So we want to take special mention for that. And today we will delight in having several of their representatives make actual presentations today. They are a valuable partner in Right Care Initiative as well as a co-founder for it. But we also want to thank each of the other entities shown on this slide, all of which are offering and have been very vital to the support and success of Right Care Initiative. Next slide. So before we start, I want to mention one thing, that we are all together here in a single fight, and the fight is against disease. And we are not really here in this consortium competing with each other, North or South California, one facility versus another. We are actually competing against disease and not each other. This was highlighted by Warren Barnes, who was one of the co-founders of Right Care Initiative. And I think this is a good motto to continue with for these meetings. Next slide. So the program today will go over a number of things. I'd like to first acknowledge our individuals who are our leaders. Oliver Brooks from Southern California, who's been a great help to us. Bob Kaplan from Stanford. Joe Sky from the Air Force, who we'll hear from later on. Evelyn Stock from UCSF, and Edward Yu from the Palo Alto Medical Foundation, both of which offer significant support and leadership to the program. Next slide. The program today we will go over after the introductions is going to highlight a presentation on COVID-19 testing, prevalence, and relevance by Terry Gilliland from Blue Shield, who is here to make a great presentation along with Scott Flinn. In addition, the second half will be key learning from the Right Care Initiative best practices to substantially improve performance by Dr. Cindy Giambroni and Marnie Baker, followed by our Q&A facilitated by Evelyn Stock. Next slide. Before we start, you might ask, why are we here today? We're here today because the information on this slide shows that there's a significant problem in the state of California. On the left, you can see the diseases or conditions which are leading causes of death in California. If we look at each of those, heart disease, Alzheimer's, and stroke, those are all focuses for Right Care Initiative, and we've worked on presentations how to reduce those. Hypertension is listed there as well, cardiovascular disease, and heart failure. Now, if we add up the number of deaths in 2018 from each of these, it's well over, in the state of California, well over 100,000 deaths from these causes. We know we have a problem. What is Right Care's goal? Right Care's Initiative's goal is to take 100,000 deaths here and reduce it to 0. Now that may seem overly aggressive and optimistic, but that is literally our goal, to prevent all of these preventable deaths at this point in time and make efforts to do that. Now, Shown on the left were the 2018 leading causes of death. Added on the right side of the screen is a new cause of death in California, COVID-19. And as you can see, in California today, we have had over 15,000 deaths from COVID-19. And soon you can see, compared to the group on the left, it's going to become very soon the third leading cause of death in California for this year. The deaths in the US are shown below. Unfortunately, over 200,000 deaths. And unfortunately, today, we pause for a second because we have now had over 1 million deaths from COVID-19 in the world today. So the purpose and the mission of Right Care Initiative is to try to reduce many of these preventable deaths. And as we learn to do that, two of the ways that Right Care works on is education, teaching, and providing tools of how to better prevent death from these causes. So education and tools is one of the great aspects of Right Care Initiative. The other is what I call the 1-2 punch. Not only do we provide the tools and the way to do it, we then check on how effective each of the facilities, each of the areas of the state is doing for that. And by looking at outcomes and providing feedback to institutions, individuals, and organizations, we can make sure that they take full advantage of the information and education we've provided. And this outcomes checkup, data review with these is not meant to be punitive, it's meant to be supportive and allowing them to find further ways of improving their delivery of care and preventing cardiovascular death and improving their outcomes. Those are the 1-2 punches of Right Care Initiative. And to give us more detail of how we're doing that and the right 2 punches, I'm bringing in our right and left punch or glove, Hattie Hanley, who is the co-founder of Right Care Initiative, who is actually the academic and personal passion behind Right Care Initiative, who will explain some of these programs, and Joe Sky, who will cover the air coverage for that from the U.S. Air Force, who will also describe some of the tremendous benefits that they've been able to see and facilitate with Right Care Initiative. So Hattie, number 1 punch. I hope you have a great left hand.
Thank you, Bill. I want to let you all know that we are a community of people who are passionate about preventing unnecessary heart attacks, strokes, amputations, blindness, heart failure, SARS-CoV-2, diabetes. Let's prevent them, and if patients get them, let's manage them better. So we've found that this synthesis of some of the strategies is very helpful for organizations to go through and see, are they deploying these best practices that are used by the very best health systems in the world? So I would just encourage you all to review that carefully at some point. And oh, it's so delightful to see more of our leaders joining. I see Dr. Carol Zaher, who I was thinking of so much today with the challenges you're facing. Dr. Carol Zaher, cardiologist from Southern California that helps us lead our work down there. Next slide, please. So we are a data-driven organization, and you can see actually both in the slide before you and in the slide that I use as my background picture that we drive improvement through data. So yes, we have a lovely group of superheroes, I'd have to say, around the state who have been joining us over the years. This project first started on my desk at the Department of Managed Healthcare in 2006, actually, when I was working with Governor Schwarzenegger on health reform. And I was asked to review thousands of pages of data with my training from the Harvard Kennedy School of Government and my background in science to really build up the quality portion of the work that the Department of Managed Healthcare and the Department of Public Health were doing. So I came across the figures for diabetes, blood sugar control, blood pressure control, and cholesterol control. And I literally almost fell out of my chair. I was so disturbed by what I saw. And I called my colleague from the Kennedy School, who was at the National Committee for Quality Assurance. And I said, you know, before I get too stressed out about these California numbers for the California health plans, at that time I was looking at both medical groups and health plans, I said, can you put it in context for us? Richard Sorian is his name. He then went on to be a big shot at Health and Human Services. But so he did a special run of data for me because he used to sit next to me in class for 2 years. So the networking aspect of the Right Care Initiative is very, very important. So we drive performance improvement for the reason of stopping preventable strokes like the one that killed my mother so many years ago due to uncontrolled hypertension. It's just completely inexcusable to me that anyone would die of hypertension now, given that we have the tools and we have the knowledge to do it. And I want to compliment our statewide chairman, Dr. Bill Baumer, who has led our Capital Region group to much greater heights in terms of controlling blood pressure for diabetics as number one. So I think Dr. Flinn, who helped me with our San Diego group many years ago, co-chairing that one, his group at that time, Arch, was the top performing group in hypertension in the state. So I'm just so thrilled to be able to say that all of the medical groups in the Capital Region now, which is a great stride and a great challenge for the Bay Area to achieve this same level of performance. Bill Baumer really inspired this incredible performance improvement that you see at Sutter IPA, Sutter Medical Group. To have all of the medical groups getting their diabetic hypertension rates to above 70% or above, it's really, it's remarkable. So thank you for the many leaders that help us. Next slide, please. So I want to say that thanks to, the amazing group of people that have come together at a regional level, now in 4 communities, our work has come to the attention of the U.S. Surgeon General, Dr. Jerome Adams, and the Million Hearts program. And Janet Wright, the former director of Million Hearts, called me a little over a year ago and said, hey, Hattie, I know you know everyone in Sacramento, and the Surgeon General would like to have a meeting with the private sector. He's going to be in town. And we ended up having a 4-hour roundtable with him. And Scott Flinn, Joe Sky, and Bill Baumer were right there with me in this incredible discussion of addressing hotspots in California and beyond. So next slide, please. Betsy Thompson asked me to come back to the Centers for Disease Control this time last year to be in a private meeting on tackling hypertension nationally. Now, Betsy had been my co-chair in Sacramento before she left for her position as the head of cardiovascular disease at CDC. So you see her there in the top left corner in her white uniform, and that's me in green. And then I have Bill Baumer there from UC Davis, and our original co-chair of the Capital Region there, Dr. Jose Revelo of Sutter IPA. And then we have Dr. Keith Emmons, who is our heart failure co-chairman and the medical director of StemCal Medicaid Health Plan in Santa Barbara. Then we have our fearless Dr. Scott Flinn with Dr. Steve Chen from the University of Southern California, our champion for adding the pharmacist to the care team. So when Betsy called me and said, would I come? I said, well, can I bring my peeps? Can I bring my leaders with me? And she said, bring up to 10 people. So I invited the people that you see here, including Dr. Oliver Brooks, who is the immediate past president of the National Medical Association, who was introduced to us by our heart failure co-chairman, Dr. Keith Emmons. Then the great surprise, the most wonderful surprise, where you see Dr. Thompson lifting off the meeting. She has our right care triangle on that very first slide in the National Hypertension Roundtable kickoff meeting. And then right below the next slide you see, and it's hard to see, but that's our publication from the Health Affairs that shows that we, in our initial very highly funded National Heart, Lung, and Blood Institute pilot project in San Diego, we were able to drive, our work is associated with driving down heart attacks by more than 20%, and the severe heart attacks, the acute myocardial infarction hospitalization rates, to be specific. And then you see Dr. Bill Baumer there passionately leading the charge on a public education campaign, which we desperately need to do. Next slide, please. So this was the greatest email I ever got, I think. I've had a lot of great ones, but at 9 a.m. on January 3rd, I received an email from this gentleman in the sunglasses, Larry Sperling, who said, hey, I'm the new director of the Million Hearts program. I'd really like to learn more about the Right Care Initiative, and I will be in San Diego doing grand rounds. Can you introduce me to some of your leadership? And I'd like to learn more about the program. Let's see if we can spread it. So I just happened to be running Los Angeles University best practices the day before. So it was a easy drive on down to San Diego, where I hosted a dinner for him and his wife and one of our early sponsors, Jack and Judy White. So that was a wonderful, both social and very intense scientific discussion over many days. I also want to say that Dr. Sperling did speak to our group this year on August 10th. And here in the top left corner, that map is just a little spooky. So I had worked on pandemic preparedness and bioterrorism preparedness for the Little Hoover Commission right before I started working on the Right Care Initiative at the request of the governor's office and the director of the Department of Managed Health Care to do something on quality. But I was still very interested in infectious disease. So this is a map that I'm standing under with Fleetwood Loostelot, who is one of the leaders in cardiovascular. And he was showing me around the operations center for outbreaks and so forth, and CDC in general. And I asked if we could have a picture under this map of the infectious disease outbreaks around the world through time. So, that was only a few months before the pandemic broke out. And I'm just so appreciative of our scientific colleagues both in the private sector and in biopharma and health systems, and the scientists in public health. Is just an incredibly challenging time. Next slide, please. So Dr. Betsy Thompson joined us for our last in-person all University of Best Practices gathering at Sierra Health Foundation in the Capital Region. And I just want to call out that our talented Dr. Balmer there with the umbrella is just such an amazing teacher. He used the prop of the umbrella to teach, and he uses various ways to get the physician's attention. So he was teaching, why do we need to lower that blood pressure, and teaching about the sprint trial, et cetera, by saying, if you have the level too high of your umbrella, then in a rainstorm, you'll get rained on. But if you pull it down close to your head, the analogy goes, then you'll stay dry. So it's, that was absolutely brilliant, Bill. Then you have Dr. Thompson to the right there, with her lovely demeanor, helping me to co-chair that meeting, while Richard Figueroa from the governor's office, who I've worked with since 1997, speaking at our summit. And I will just say, you know, we always celebrate people's success with awards. And our community has been building and building for 14 years now. And this annual meeting, I hope someday we'll get back to meeting in person, draws people from not only across California, but some of our federal colleagues who help us. Next slide, please. I would like to introduce our co-chair, Dr. Joseph Skye, who helps not only with our Bay Area chapter, since he's from Solano County, but also our Capital Region chapter. So Dr. Skye is going to help me with the photo montage related to our regional groups. Dr. Skye has been promoted, I learned this afternoon, from being Chief of Cardiology to being the Associate Chief of Staff for Travis Air Force Base. And with that, he has reduced his cardiology role to lead the whole health system, and is now the Chief of Preventive Cardiology, where he has very special gifts. He grew up in one of the blue zones. For those of you who are familiar with that, I'll let him mention that further. But he has done amazing service with the astronauts of our nation and the Air Force. And he was so dedicated that even when he was posted in Iraq, he would call into our planning meetings. So I have to say, you know, bless you, Joe Skye, for your service to our nation and to the Right Care Initiative. And with that, next slide, please. Please unmute Joe. Thank you, Joe.
Thank you, Hattie. Details, I guess, matter a tiny bit. It was actually Afghanistan in 2018. Iraq and Kuwait were a decade earlier. So, but thanks. So now that we've had a look at the national level for the Right Care Organization, I think it's so important to think about the regional level. And this is where just a few short years ago, I was lucky enough to attend my first meeting. Actually, Warren Barnes invited me. And from the moment I attended, I realized that there was opportunities for me to learn and eventually to present. But anyone who comes, regardless of the level that you're at in your career, you will be able to associate with and have great mentoring experiences or mentoree experiences, as the case may be, appropriate to where you are. And so the Right Care organization brings these opportunities together in a way that I've never seen before in my lifetime. And so to point out some of these types of things, let me draw your attention to the middle picture on the top. In this photograph, we have Hattie and Bill Hanley from the Capital Region. And in the center is Dr. Matt Budoff, a world expert on coronary calcium and the science behind screening. And then we have someone from the American Diabetes Association. And lastly, a patient advocate, Victoria Dupuy from No More Broken Hearts, founded in honor of her late husband as an innovative way to bring coronary calcium to patients. And these are just the types of innovations that can get started, and then once they're started, get highlighted at the Right Care organization. And then I'd like next to bring your attention to the bottom right. Another patient advocate, a stroke survivor, Bruce Baldwin, is standing next to Hattie, and on Hattie's other side is Liz Helms, a prominent nonprofit here in California. She's the executive director for, and that's the Chronic Care Coalition. And alongside her is Dr. Labara from the State Department of Public Health. And so in these regional meetings, we just have these tremendous opportunities to bring people together in the spirit of Dr. Barnes with friendly competition towards disease. Next slide. And so for the Right Care Initiative in the Bay Area, Silicon Valley, the newest group, I'd like to bring your attention to the top left picture. So we have Chuck Tennisketter here, who is a stroke survivor himself. And over the decades, his nonprofit that he formed is why we have such incredible care for strokes in the Bay Area. As an advocate, he's been out making change, and he has presented for the Right Care Initiative several times. And standing next to him, of course, is Hattie, and then Drs. Vora and Dr. Alpers from Stanford that have been part of the innovation that includes software that helps find and predict the best way to save brain tissue after a stroke. And for me as a cardiologist, this is reminiscent of our career field a decade or more ago when we learned how to best save heart tissue after heart attacks. This type of innovation is presented at the Right Care Initiative in a way that we can all learn from it and bring your own organization up to speed with the best innovation out there. And next, I'd like to bring your attention to the middle picture on the left. And this is about a community health organization, the Asian Heart Center, led by Dr. Cesar Molina. And as many of you know, the lost heritage of many of our tech imports who work in the Silicon Valley has resulted in some of the earliest cardiovascular deaths that we've seen in America. And his work to pioneer innovative ways to undo this and seek prevention is remarkable. And next, I'd like to continue over to, in the middle, we see Dr. Marilyn Stebbins, a pharmacist at UCSF. Early in this year, she told her personal story of COVID and surviving this. And she set the tone for the Right Care Initiative as we sought to find the best expert and best evidence-based medicine that we could present to our members over the last few months. And I think this type of rapid pivot to timely clinical challenges is illustrative of the environment that we have at the regional levels with the Right Care. And then just above Dr. Stebbins is Dr. Sidney from Kaiser, one of the founding physicians of the Cardio Research Program, a seminal program that showed that coronary calcium was very predictive of heart disease in the young. And this clinical information has turned out to, of course, yield benefits over the decades. And then lastly, we'll go down to Dr. James Schultz in the bottom middle there. This is another type of presentation that is often made at the Right Care Initiatives. We have a medical director presenting evidence-based medicine on how to make a difference at a health system level so that we can all learn better techniques and better methodologies. Next slide, please. And then for the Los Angeles Right Care, I'd like to bring your attention to the top left. On this day, the focus was women's cardiovascular risk and disparities. And the presenters were Dr. Margot Manisian, along with Dr. Carol Zaher, and Dr. Stephen Chen from pharmacy. And by this typical presentation of a multidisciplinary approach to challenges, the Right Care sets the way in being able to focus on the objective ways to make things better. Down in the bottom left from the Health Partners of Minnesota is Dr. Karen Margolis, and she's one of the early innovators of using pharmacists along with physicians and telehealth to be able to treat hypertension. And we all know that this has become a game changer for those of us that are lucky enough to have pharmacists, clinical pharmacists integrated into our practice. And then over on the right, the top right and the bottom right, I'd like to bring your attention to Dr. John Overtveit and Dr. Alan Fremont, the late Dr. Alan Fremont, who was a co-founder of the Right Care Initiative. What these two have in common is that they have worked directly with the Right Care to integrate with the RAND Corporation, because they both have been affiliated with the RAND Corporation. And most of us know that the RAND Corporation is one of the earliest think tanks devoted to the objective analysis of problems, especially important to the military over the years, and now to healthcare. Next slide. And now on to today. I have the privilege of presenting two speakers from Blue Shield of California. The first is Dr. Scott Flinn, and he is a fellow serviceman, a U.S. Navy veteran, served with the Navy SEALs as an undersea medicine physician, as well as a leader in the Navy's medicine program in charge of healthcare for all ships worldwide. And now is a regional medical director for Blue Shield of California. And his involvement with the Right Care has been extensive. First as a co-chair in San Diego, and then as a co-founder of the Bay Area Silicon Valley Best Practices Group, and now a member of the Right Care Technical Expert Group. And most recently, he has decided to join our Sacramento area as a fellow co-chair here in Sacramento. So it's a privilege to be able to introduce a fellow veteran. And in some good Air Force Navy rivalry, I'd like to point out that for anyone that ever wonders about the challenges of medicine at sea or underwater medicine, I would encourage you not to do that. At least that's been what I've thought whenever I've flown over the coast of Southern California or South Korea in the backseat of an Air Force F-16. And next slide. I'd like to introduce the Executive Vice President for Blue Shield of California with regards to health quality and affordability. I'd like to point out that Dr. Gilliland started in California. He attended undergraduate for college at Stanford, and then UCLA for medicine, and then back to Stanford for an MBA, and now has had an impressive career as a physician leader, and now back in California with Blue Shield. One of his programs, Wellvolution, I would encourage everyone to look at. This is an impressive program that focuses on so many of the things that are at the core of the Right Care values, which is prevention, weight, hypertension, diabetes control. And it's just a joy to see somebody who has decided with the many choices we all have in our careers to focus on things that are so valuable for prevention. And so now I'd just like to go ahead and give Drs. Gilliland and Dr. Flinn the floor. We look forward to hearing your presentation.
All right. Well, thank you so much, Joe and Bill. I just want to say from the outset, I'm so impressed with what Right Care is doing to improve the health of Californians. And as you look across the state, and I did when I first came back here to work for Blue Shield, and then of course across the country, the #1 disease that we have to contend with is hypertension, as we pointed out earlier. And what's unfortunate about it is that for a long, long time, it's not been that well controlled. And so I'm just so pleased to see you get after it, because it helps our members, it helps our population. It's just the right thing to do. And as I'll get to at the end of the talk, it's the place where we need to focus for really addressing some of the health disparities that are the blight of our time. But right now, the blight of our time happens to be COVID-19. And none of us would have thought that we were going to be here 6 months ago. And so we're going to spend a little bit of time, next slide, on maybe some of the things that we've learned at Blue Shield of California. What the heck does a health plan have to do with a disease that's predominantly hitting the delivery system? What we learned from it, and where do we go from here? And then maybe a few minutes for discussion. Next slide. We started at Blue Shield with some very early recognition that this was going to be a problem way back in February. And as Bill and I were talking earlier in the meeting, in the pre-meeting, we discussed that first known case of community transmission that came out of Solano County, or Sonoma County, and Solano County, and went to UC Davis. And for us, that was a moment at Blue Shield that said, we need to get after this, and we need to really invest in testing, tracing, and isolation. And so literally before this first task force meeting with the state, I spent 2 weeks with Paul Markovich, who's our CEO. And if you don't know him, he really gets after it. And we worked really hard around trying to figure out, how do we get the sourcing from South Korea into the hands of places that can actually do the test in the United States. And I'll be honest, we failed after 2 weeks, and we realized we had better get to being participants in something that's much bigger than Blue Shield in order to have a positive impact on this disease. And so with that, Paul, I think in a pretty, not presumptive way, but recognizing what needed to be done, approached the governor's staff and said, we'd like to invest and participate in a public-private partnership with the state of California. And we launched and invested, I think it ended up being 20 Blue Shield employees, myself included, and a good chunk of my team, to dive in with the task force and really drive to what started out as 2,000 tests per day in the state of California, to over the next 3 months, a 50-fold increase to 100,000 tests per day. And I would say in retrospect that what we anticipated was, and we spent a little bit of time on this, but probably not enough time on it, we were trying to build for something that was in the past. And so we had a goal of 100,000 tests. And what I wish we'd done a little bit more of is to build for the future, which was much more than 100,000, because it turned out the disease accelerated much faster than our testing could keep up with it. Next slide. We also felt as a health plan that we had a specific obligation to our members who were at high risk for contracting COVID and for developing morbidity and mortality from it. And so we used artificial intelligence-based algorithms to figure out who's who in the zoo and do some specific outreach to 153,000 members. We provided them with information and resources to help them understand the disease. And then for those who did contract to the disease, we had some special post-disease follow-up to coordinate for their needs. And as everyone knows, this can have a long-standing effect on the person, and we're deeply vested in that. Next slide. We also felt like we had an obligation to our hospital and provider partners, because we knew that they were getting overwhelmed with calls, people that were concerned, how do I approach this? And so we provided a free digital triage tool in conjunction with a company called Giant, so that there was provider-specific information that those who were in the local community could use. We felt like we helped our providers, for those who decided to take us up on it, a lot by decongesting their call lines and making it so that they could have better use of the people and the personnel that they did have online. Next slide. I'd say we learned a lot. First and foremost is that we weren't ready for COVID-19 either as a globe, certainly in the United States. We were not ready in the state of California, and we weren't ready all the way down to the county level. And one of the eye-opening things that I learned from being on the California State Testing Task Force is that there's no politician that actually controls the local events at the county level. And in the state of California, we have 58 counties, and they are all governed by their local community boards and make decisions relatively independently. None of us were ready for this. And if you go back to the globe and you say, well, who was? It was really those few countries that really took the first round of SARS way back in the early 2000s. And they said, we're going to build an infrastructure that includes a government response, a laboratory response, interconnectivity of data, and we're going to develop some social contracts the next time this rolls around so that when it does come, we're going to be ready for it. Second thing we learned is that our healthcare system is vulnerable in a lot of ways. We're simply not set up for it. We also have a payment system that doesn't necessarily reward sharing of data. Those are things that started to emerge as, wow, we really don't even have the systems to monitor on an active real-time basis how many beds we have available in the ICU or in our hospitals. One of the really interesting conversations we had early on with Hospital Corporation of America is that they literally did set up a command center, and they knew exactly where COVID was hitting and where it wasn't. They knew exactly how many masks and ventilators and the whole 9 yards. And when I asked them, well, geez, can we use that system and graft on the rest of, say, California's hospitals so that we can have that same kind of visibility? The answer was, well, yeah, we could think about doing that, but nothing in the short term to really help us with the visibility into what's happening inside our communities. And then finally, these systemic issues really do continue to permeate our healthcare system, whether it has to do with health inequities, whether it has to do with how our systems are set up for success. We learned a lot for those areas that were particularly exposed from COVID-19. Next slide. As a result, we've spent a little bit of time on where we go from here. Next slide. And we particularly think that a couple things. Number one, we had better be ready for the flu this fall. So there's a little bit of a commercial interruption, but it's also an important one. We think that the flu shot's pretty important this fall, so we encourage our members and of course encourage all of you to get the flu shot. And then for those that you have influence over, it's a pretty important time to do this. Next slide. We also know and expect that, and there are enough cardiologists on this call, I'm not going to embarrass myself with my lack of knowledge, but we do know that COVID has an impact on the heart in ways that we probably don't know everything about yet, but we're also anticipating that there's going to be an increased incidence in all likelihood for heart failure over the long haul. I think that was either 9 or 10 or somewhere up in there, might have been 11, Bill, as leading causes of morbidity in the state of California. This is an area where we're going to need to pay special attention because, as we all know, different viruses can induce a viral cardiomyopathy. It looks like COVID is going to have a special impact as well that we'll need to monitor. Next slide. We also have a pretty strong point of view that we can't keep doing what we have been doing and expect a different result. And so next slide. We're working very hard to get out there with a couple of things. One is that, and this is readily apparent in the California State Testing Task Force, is that our health data has tended to be very siloed. It's not interconnected. We say that it's interoperable if we can exchange PDFs and then the physician scans it in the record and Lord knows if they're ever going to find it again. We have to make it so that the data is widely available and interconnected. And this is, and I'm just being very specific, this is not just by having Epic Care Everywhere or whatever Athena has to offer or Cerner. It really does mean that we have to get away from this notion that the data is ours as providers or whatever entity we're coming from. It's actually our consumers, our members, our patients. It's their data, and we have to get it out there where it can be used. Second thing is that we saw and really experienced that warehousing fell short in a lot of ways. We had poor inventory controls. We didn't have any way to get even the basics around PPE. We had challenges with having testing reagents available. We had challenges with making it so that those labs were interconnected with a very simple interface. Very difficult to match supply and demand for testing. And finally, we need to have much better central command, if you will. This is not control, but it is some sort of command visibility. And anybody who's been out there on the East Coast, where I spent a little bit of time, being an incident commander is something that you can learn how to do. And it's really valuable training. It's free, it's from FEMA. And we need to think better about what's this look like going forward to create these incident command centers that help to manage crises as they occur. We certainly weren't ready for it this time around. Next slide. We also have a point of view that now's the time to get to a different place in healthcare. And I'll detail this a little bit in the next couple of slides, but this is our Venn diagram of all the different inputs or components to where we believe we need to get to in healthcare that includes holistic health, that includes the personal care that we all provide in the provider space, and it also needs a high-tech and high-touch support. We aren't going to do all of these things in 1 year, but we are taking chunks of these out that we're working on over the next couple, 3 years to really make it so that we're driving change within the healthcare ecosystem. Next slide. We're getting some really good results and feedback from this. First, and this is not just our experience, but we're getting after these folks that we think are affected by the social determinants of health. We use a model called a community health advocate, and we've had 1,000 patients who've been screened for those social determinants of health and have some really meaningful and chunky interventions. This is stuff that most physician offices, provider offices, they do not have the time and maybe even the skill set to really get in there with the patient member and figure out what are those things that are driving some of those things that affect your health. We've had a ton of increased demand for our virtual visits. And then we also believe that shared decision-making is a critical component to changing the way healthcare is delivered. All of us know that there are preference-sensitive conditions that deserve a healthy conversation about what the options are. And sometimes when all the facts are presented in a relatively unbiased way, sometimes choices are different. And then finally, we have a notion that as a health plan, we need to get out of the way. And one of the ways we get in the way is either with prior authorization and figuring out the claims and who's going to get paid and who's going to get paid how much. We'd like to reduce that friction in the system with real-time claims. Next slide. So these are the kind of the main key components for primary care and specialty care reimagined. We're going to market with this literally as we speak. And it has not only the value-based payment contract, which by the way would help to alleviate some of the pain of fee-for-service medicine for a typical practice, but also has that shared decision-making, the real-time claims, the practice-level consulting services built in so that physicians can be more effective and more efficient. Next slide. We also are focusing more, as everybody else has. If you can't see people in the office, then you have to have alternatives, both in the telehealth space, but then certainly also for behavioral health. So we're really pleased, as Joe pointed out, with our Wellvolution program. I love this part about 83,000 pounds lost with blood sugars getting under control and some of those chronic conditions reversed. We have some incredible patient testimonies here that we'd love to share in more detail at some point, but these are great programs. Next slide. And then finally, just to spend a moment on this, what's really become apparent is that COVID-19 has affected people of color differently. And it's particularly true because this is not, and this has been true for a long time, that we have not addressed those health disparities, particularly in people of color. And I spent a good chunk of my career in Washington, D.C., where we were very focused on Prince George's County and also in the district in wards 1, 5, and 6, where there's literally some of the worst healthcare in the world. It's third world healthcare right there. And it's our obligation, we all know this, it's our obligation to do something about it. And so we're pretty serious about it. We want it to be part of who we are, about what we're addressing. It means at the very granular level that we have access to, and then also addressing those access to care, and then addressing those health disparities that particularly affect people of color, like hypertension, like stroke, like cardiovascular disease, like screening for cervical cancer, colon cancer, breast cancer, prostate cancer. Those are just abominations, really, in a nation like the one that we have. And so we're very focused on it. We're going to take it forward with health equity. We'd love to have partners in the cause. We obviously aren't going to be delivering the care ourselves, but we sure can promote that care inside the delivery system. So I think for us, it's been a little bit of a pulse check at Blue Shield, which is to say, what are we going to do about it, and what will we do to put our name on it? So I'll stop there. Those are the slides that I had to present. I don't know, Scott, if you had any additional comments to make. Otherwise, we can certainly open it up for questions.
Hi, Terry. Thanks. Again, I think just to emphasize on a couple of things you talked about there is long-term effects. This will be very interesting to see what happens. We don't have any idea, and we're just starting on that journey. And certainly the healthcare disparities, which you have there on your last slide, vitally important. Got to figure that out. That's all I have.
All right, thanks. So we'd love to entertain questions, or we can move on to the next topic, either way.
Terry, this is Bill Baumer. I have a quick question for you. Very good on the testing. That's sort of your first level. Let's say you test someone and they're positive, and then obviously you follow them through their either development of symptoms or not. Does Blue Shield have a plan for further testing? Let's say you have tested positive and you have mild symptoms. We have recommendations from some consensus panels of following up with a troponin level to see if there's cardiac involvement in those individuals. Some even recommend if you have more symptoms, an echocardiogram looking at LV function, because we are obviously in the early stages of this, but we realize once you're positive and you have even mild symptoms, there is some late changes associated with this disease. And is Blue Shield using their digital network to reach out to those people to say, okay, you've just tested positive. We're now recommending add-on tests at a 2-week interval or something like that for follow-up of the late stages of possible disease?
Yeah, thanks for asking the question. And we are still relying in some ways on the developing science behind it. So I'd say a couple things. One is that we fully support what's supported by the science. And I'll go back and check, because it's a good call out, to make sure that we're doing the appropriate reach out for the appropriate follow-up tests for those people that have tested positive. Because it's not just about arranging transportation. I think that's your point, is that we also have to follow up and make sure that they're getting the appropriate screening for things like heart failure. So I think I saw in one of the consensus panels, Bill, that there's a recommendation for at least an initial echocardiogram to assess heart function. Is that correct? Is my memory correct?
Yeah, depending on the level of symptoms. And you have a great network and a great digital system. I would say the next step is to perhaps stretch it a little, and because the disease is stretching our knowledge and our capability in this case.
Yeah, thank you for that.
Dr. Gilliland, this is Joe Sky. I'd like to emphasize that I appreciated your comment about the incident command training. The Air Force has made all of its physicians do this for years. And in this last year, between the fires and COVID, it gives any of us who aren't at your level of leadership an opportunity to see the decisions that have to be made. So I would encourage anyone, I agree that it's available for free and it's a good thing out there.
Yeah, thanks for the additional plug. Watching some of the meetings and the behaviors within Blue Shield of California, I can tell you, I encouraged it internal as well. It's like, guys, there are different ways to do this and it's better.
Yeah, exactly. Those are great points. I really appreciated that and telling the truth about what it's like to be at your level, you know.
I see that some of our other leaders have joined us, including Dr. Evelyn Stock from UCSF, and I have to say that Dr. Stock is working at UCSF Hospital today doing heart procedures. So if she is not able to speak much today, that is why. And our other co-chair for the Bay Area, Dr. Nirali Vora, is out on maternity leave. So, and I know that Dr. Ed Yu from Palo Alto Medical Foundation is also seeing patients today. So it's been an amazing thing to see people gather from not only across California on this video format that Dr. Flinn encouraged us to adopt, but also increasingly we have guests from around the country, including from National Heart, Lung, and Blood Institute, who I believe Dr. Hassan is with us today. Evelyn, are you able to comment now that we see that you've joined us, or Dr. Yu? Oh, good, there's Evelyn.
Hi, Hattie. Hi, everyone. Thank you for having this great meeting. I'm glad I could join. And as I was listening to Dr. Gilliland's presentation, I start to ponder on how important it is that there is a conscientious effort to make health data more widely available. And the reason I say that is because this recent JAMA article really was felt by many like a splash of cold water, but I'd like to put it in context a bit for everyone. The JAMA article is very interesting in that it shows us that people after 10 to 12 weeks do have these cardiac inflammation or these sites of cardiac injury. However, there is no clinical context for these findings. So what we have seen is that in people, you might find these areas of injury without a clinical connotation. And that's very important because if there is no clinical side to this, we have to think, are we going to change our management and what are we doing with these findings? So that is why I've been talking to my colleagues nationwide and haven't found that people are seeing this shower of heart failure. In general, what we're seeing is people with pre-existing conditions such as hypertension, which Dr. Gilliland so eloquently put it, need to be managed better. And those are the people that we're seeing presenting complications. So I just want to say that it's not as bad as it looks right now from this JAMA article maybe, and we do need more data. The other thing is that virtual care has, for us, been key, lowering the barrier to access care. And for me, it's been very rewarding to be able to receive messages from my patients. I tell them, if you're worried about COVID symptoms or anything, whenever you wake up in the middle of the night and you're, roasting yourself with these questions, just write them up, send me a message, and in the morning I can have an answer for you. And it's, part of our role is to reduce the anxiety, reduce this terrible uncertainty that people are living in. So thank you for making that available to your members. I think it's really key. I always tell people, don't worry alone. Involve your doctors. So thank you. And I look forward to staying on the program and continuing to hear these great.
Yep. Thank you. All right, Hattie, please transition.
Thank you so much for your wonderful presentation, Dr. Gilliland, and we hope to have you with us more often if you can be. I think you're going to be so excited about the next group's presentation, because it's really going to, because your numbers are a roll-up of what the performance is from your contracting medical groups, of course. And I just love the story that Dr. Cindy Jambroni, our heart failure co-chair, is going to relay about how she learned, and her entire leadership came to Right Care Initiative when Scott Flinn was speaking along with Dr. Joel Handler in January 2019 at our LA group. And Cindy Jambroni brought literally 10 of the top leaders from Memorial Care Health System, both with the IPA, Newport Physicians, and their integrated medical group. They came to learn the strategies that are used by the top performers that were relayed by both Scott Flinn and Joel Handler of Kaiser. And lo and behold, she, as the head of quality improvement, leading quality improvement for the MSO there, was able to help them to improve their hypertension control by 13% in 1 year. So with that, Dr. Ed Yu, one of our other superheroes from Palo Alto Medical Foundation, is going to do the formal introduction. Thank you so much, Ed.
Oh, you're welcome. Thank you very much. Well, it gives me great pleasure to introduce the next set of speakers. They are our peers in Southern California from Memorial Care, a very high-performing integrated system in Southern California, and I'm just delighted to have them here today. And that's one good call out that despite COVID and in-person meetings we can't have, we're leveraging technology to have virtual forums to make this possible. So Cindy Jambroni, it's a kindred spirit. Her formal title, she's the Director of Performance Improvement for ACO Pharmacy Risk in Memorial Care, and I have conversations with her about ideas about performance improvement on our systems. And so I'm so delighted to have a chance to learn from her. Besides overseeing pharmacy risk and building ACO performance, she has a specific passion around congestive heart failure that Hattie has mentioned earlier. She has been very active in the healthcare initiative for over a decade, and co-chairs the heart failure work group that in Southern California. So I'm really looking forward to hearing Cindy's story and what she's going to share. And joining her today is Dr. Marnie Baker. I'm also very delighted to have her here today as well. Just by coincidence, Marnie and I share several statewide committees together, so I have a chance to see her in action and really love her passion and her expertise about quality measurement. So I'm just delighted to have her. But again, by way of letting you all know, she's a practicing physician with Memorial Care, and she serves as Medical Director of Performance Improvement and overseeing clinical quality programs. She's also on the Technical Measurement Committee of Integrated Healthcare Association, where I'm also a member of, and she also sits on the Clinical Quality Leadership Council from American Physicians Group as well. She has a medical degree from Tulane, and she also has an MPH from Gilliland as well. So she brings not only stellar academic credentials to this, but she also brings a lot of practical experience as a practicing clinician and a wealth of experience leading quality and performance improvement. So I couldn't be more delighted on behalf of the Silicon Valley Group to welcome Cindy and Marnie, and we look forward to your presentation.
Well, thank you very much. We very much appreciate the invitation and the opportunity to be here today and share with you an example of the benefit of participating in the Right Care Initiative. And as Hattie mentioned, what Dr. Baker and I are going to be doing for you today is sharing our story about how we took key learnings from a specific meeting that we attended in Los Angeles at RAND to apply to our hypertension initiative, which we've entitled Mind the Gap. And what we mean by that, we'll talk about in just a moment. Next slide. So specifically, what we're going to be doing for you today is to first kick it off with an overview of who we are, just to help to give some context of who Memorial Care is. Then we'll talk about why we chose this initiative. Why did we choose to focus in on hypertension and the patients in the gap in meeting the measure? What it was we actually did, what was actionable and what was measurable. And this is demonstrated by the impact of the program. And then what I will do, along with Dr. Scott Flinn, is close with some next steps and highlight a tool that we are working on, a toolbox that could be used by those who are interested in the Right Care Initiative and share our objectives. Next slide. And I think this is an action slide, so if you can hit it again, Megan. So Memorial Care is probably best known for our largest hospital, which is Long Beach Memorial Medical Center. We have a number of divisions, and where Dr. Baker and I sit is in the Memorial Care Medical Foundation near the bottom here. Now, what I told Dr. Baker was that this was no reflection of our importance within the organization. It just happens to be where we're located. And underneath the foundation, we have our physician organization. We have Memorial Care Medical Group, and we have our IPA division, which is known as Greater Newport Physicians. Next slide. When you think about our physician organization that is within this integrated delivery network, we have two sides of the house. We have Memorial Care Medical Group, which has been around for more than 50 years. And then we have an IPA division known as Greater Newport Physicians. Now, Memorial Care Medical Group and Greater Newport Physicians has offices and clinics throughout Los Angeles and Orange County. Additionally, we manage about 300,000 lives across the two organizations. We have a long-standing history in capitation and managed care. Next slide. As Dr. Sky showed you earlier in his photo montage, Memorial Care was one of the recipients of the Right Care Initiative. Memorial Care Medical Group and Greater Newport Physicians are award-winning organizations for quality. And we, as shown here, here's an example of an award that we received in diabetes care. In addition, when it comes to quality, we're probably best known for what we are able to do in working with our patients with diabetes. And if you look at our performance of both the medical group and the IPA with some of our health plans, we frequently score within the top 5, and sometimes we're number 1. And I think a lot of that is because of our focus on diabetes, as well as leveraging pharmacists on the care team for these patients. Next slide. So while we do really well in diabetes, what we did recognize in late 2018 is that we had an opportunity in improving in our scores related to the management of hypertension. And what this graphic is depicting is data that comes from our healthcare registry known as COSIBA. And you are looking at data that we were looking at the end of 2018. And if you focus on the bottom, what you see are overall blood pressure control rates. GMP, the IPA, is in blue. Memorial Care Medical Group is in yellow. And what this demonstrates is that our control rates for the 2 organizations ran between 62 and 63%. And I distinctly remember sitting in a meeting with Dr. Baker and our team going, you know, we can probably do better than this. Next slide. We decided that in 2019, we were going to do better. And the other thing that happened in 2019 is there was an update to the IHA measure relating to controlling high blood pressure. What IHA had done in order to reduce provider reporting burden and drive alignment is that previously there had been different age ranges with different targets based on different conditions for various populations. And in 2019, this measure was specifically consolidated to look at patients between the ages of 18 and 85 who had a diagnosis of hypertension and whose blood pressure was not adequately controlled. Adequate control was now defined for all of these populations as less than 140/90. Next slide. Additionally, what we did is we leveraged our quality registry, COSIBA, to see if we could have a better understanding of who was driving the data. So we separated the providers into quartiles numerically. And what we discovered is that 25% of our providers, which was roughly 31 physicians, contributed 53% to the gap in patients in hypertension. So more than 50% of the patients were driven by these 25% of providers. Additionally, when we looked at the top 10 PCPs, we saw that they drove 22% of the gap in our medical group practice. On the next slide, you'll see that this information for the IPA side of the business was even more pronounced in terms of who was driving data. So the top quartile physicians, roughly about 30 physicians, contributed almost 60% of the gap in hypertension. And our top 10 providers drove almost 1/3 of the gap. Next, please. So with that in hand, we decided that we needed to create a strategic plan in order to change the paradigm in hypertension. So we identified that we had this opportunity for an intervention. The other thing that we did is in December 2018, we invited the leadership from the Orange County American Heart Association division to come and give a presentation to our quality team on the Target BP program. And I'll share with you some of the materials that we leverage for our initiative. If you haven't met with your colleagues from the American Heart Association and you're interested in hypertension, I highly recommend this Target BP program, and you'll see why in a few minutes. The other thing that we did is to identify physician champions within the IPA and the medical group. And what I mean by physician champions is physicians that are key opinion leaders locally that could help us with our messaging and strategy around getting patients to their target. Next slide. So in that in hand, we knew what we wanted to do, but we had some questions. We knew that it would probably be important to target the top quartile providers because they were contributing most to the gap. But we had some questions. The first was, did we believe the data? As Dr. Baker and I and the team reviewed the data, we questioned whether any one of our providers would have less than 25% of their patients with hypertension at their target. So we questioned how the providers were seeing this information and were they aware of it? And then we also questioned about how we might assist our primary care providers in interventions on these gap patients. And what really drove us was whatever we did, we wanted it to be actionable and we wanted it to be measurable. We wanted to be able to leverage our physician champions. We wondered whether or not academic detailing of our targeted physicians would be beneficial. And we also knew that somehow we wanted to utilize and participate in the American Heart Association Target BP program. With that in hand, next slide, we attended, and this is a screenshot of the agenda from the January 2019 meeting of our Los Angeles University of Best Practice, where, as Hattie mentioned, Dr. Flinn and Dr. Joel Handler spoke about the management of hypertension. We invited, and they joined, 8 members of our quality team, as well as we were joined by our physician champions. And we drove through the pouring rain from Orange County to Santa Monica. We swam to the meeting, right, Marnie? You can nod. To go to Rand and listen to these 2 presenters. Next slide. And what this graphic is depicting is the title slide from Dr. Joel Handler's presentation. Dr. Handler is from Kaiser, and he is the former national lead for the hypertension initiatives at Kaiser. And what Dr. Handler did for all of us that participated in that meeting today is to share a concept that he called implementology science. He shared the playbook that Kaiser used in order to achieve their great numbers. The story that Dr. Baker and I heard, as well as our colleagues from Memorial Care, was very similar to what we were experiencing in our own organization. So what Dr. Handler shared is that their control rates prior to them using this implementology science were in about the same range as we were at baseline. And this is the actual playbook that Dr. Handler showed us. So what he said is you needed 5 things in order to improve in hypertension control for your patients. You need a comprehensive hypertension registry. You need clinic level feedback in order to facilitate operational and system level change. At Kaiser, they use a treatment algorithm. They also leverage a single pill combination algorithm for their patients. And lastly, in order to combat clinical inertia, they leverage their nurses at the top of the scope of practice and use nurses to do blood pressure checks for patients who are not on target. Specifically, instead of waiting 3 to 4 months for a patient who is not at their blood pressure target to have them come back to see whatever intervention you did, if it worked or not, have the patient come back in 2 to 4 weeks and have a nurse blood pressure check to see if your intervention worked. And if it didn't work, then take a next step and do something about it. Next slide. So what Dr. Baker and I did was to bring this playbook both to our medical group leadership, quality leadership, as well as our IPA leadership. And what was interesting is both on the IPA side of the house and the medical group side of the house, they liked 3 of the 5 aspects of this implementology science. Both the medical group and the IPA physicians did not want to use a treatment algorithm, nor did they want to use single pill combination algorithm. They just felt it was too prescriptive. So the 3 areas that we decided to focus in at both the IPA and the medical group was the registry, the clinic level feedback, and the nurse blood pressure check. Next slide. The other thing that we did was to leverage the materials from the Target BP program. And what this graphic is depicting is what we affectionately call the red poster at the IPA and the medical group. What this serves as, it's a poster. It's a poster that's fairly large, but you can post it in your nurse's station as well as your exam rooms, and it serves as a clinical reminder for both patients and those that are taking the blood pressure on the 7 simple tips to get an accurate blood pressure reading. What this shows with these 7 simple tips is the impact of doing things like what happens if you use a wrong size cuff, or what happens if you're having a conversation while the patient's blood pressure is being measured. And universally, this poster was well accepted by both the IPA physicians and the medical group side. The other thing I'd like to point out about this poster is that there's a reference in very small print on the bottom, but the primary author of the rest of this reference is Dr. Joel Handler. The other thing I'd like to share is that my office became the primary housing for the red poster, and people would come by frequently to pick up copies for their office. And my office sometimes served as the confessional for poor blood pressure technique. As people would come and pick up the poster, they would share how, because of this learning and because of these tips, the importance of accuracy of blood pressure measurement was really being highlighted. Next slide. So what I'd like to share now is what we did first at the medical group side, and then I'll go to the IPA side in terms of how we rolled this out across our organization. At the medical group, we embrace a concept called lean. And if you're not familiar with lean, it's a way of approaching workflows and creating standard work across your organization in order to improve efficiency. What the standard work involved and our focus on the medical group side was, 1, to increase the accuracy of blood pressure readings, And how we did that was through training of our staff, through webinars, through on-site visits. And we brought the nursing staff together to talk about the red poster, the technique, and to promote the accurate measurement of blood pressure. The other thing that we did was, again, to leverage our staff at the top of their scope of the practice, so that if patients were not at their blood pressure target, we would have them come back in 2 to 4 weeks in order to combat clinical inertia. Next slide. What this graphic is depicting is, again, data from COSIVA. So what Dr. Baker and I decided to do in our team was, we had created these standard works, we rolled it out to the pilot site, and then we used our hypertension pilot to kind of try it on. And we rolled this out in the beginning of July 2019. And what this graphic is depicting on the top are our commercial blood pressure rates at the various pilot sites, and on the bottom is for our senior patients. And what we noted is, in July 2019, the pilot sites, in terms of their average control rates for hypertension, was very close, if not the same, as what we were seeing at the overall Memorial Care average. What we saw over time by adoption of techniques and the standard work was a divergence and an improvement on control rates at the pilot sites versus the overall Memorial Care average. In both the commercial and senior patients, we saw about a 7% difference in control rates between July and January. Next slide. So that's what we did on the medical group side. What did we do in the IPA? So the next few slides are our approach that we took in the IPA side of our business. So, on the medical group side, we have employed physicians that work at clinic sites. On our IPA side of the house, we have independent physicians who may have their own individual practice. 65% of our IPA physicians are on an EMR system. Another almost third either use paper or some other form of medical records. So not a single system, and not large clinics, but more individual practices. Next slide. So leveraging our physician champion, we decided that the key core messages that we were going to focus in on the IPA are listed here. So the first was, if your office uses a manual blood pressure cuff, please don't round the blood pressure reading up. So if you need to record the blood pressure to what you measure, and please don't round it up. Next was, if the patient's initial blood pressure reading is elevated at the start of the visit, the measure allows for multiple readings during the same visit, and the lowest diastolic and lowest systolic measurement will be captured. And lastly, really reinforcing the concept of combating clinical inertia with the nurse visit 2 to 4 weeks if the patient is not at their target. Next. Then the other thing that we did is that our quality team that works on the IPA side of the business and I had a roadshow. So we would bring our messages around hypertension management and the Mind the Gap initiative at our PCP forum, which is a meeting that occurs every other month where all the PCPs come together. So we reminded them about our initiative there in partnership with the American Heart Association. So we brought in the leadership of the American Heart Association, and we did presentations at our office managers meeting, where the operational staff comes together. And we did presentations about the materials for the American Heart Association, and we had a booth where people could come and ask us questions. I attended practice leadership meetings with key physicians. And then the last thing that we did is, because our offices in the IPA are distributed throughout Los Angeles and Orange County, we created a educational WebEx series. And again, this is pre-COVID, but we had a specific WebEx on the management of hypertension, where we talked about this initiative. Next slide. So this graphic is showing the results from our pilot that we did at our IPA. In blue, you see the baseline from calendar year 2018 for our IPA pilot sites. We kicked off the initiative in the beginning of April, and then we started measuring how our program was impacting blood pressure control rates. And you can see for both our commercial and our senior patients, steady improvements over time. Next slide. So how'd we do? What I'm showing you here is our results for our controlling hypertension rates in both the IPA and the medical group side. And as Hattie mentioned at the beginning of the presentation, we had a 13% increase in our control rates for the IPA. So we got to 71%. The medical group side, while it did see some improvements, was less so, and we had an increase of approximately 5% for our medical group. So overall, at the end of 2019, we decided that what we were going to do on the GMP and medical group side of the foundation was to roll this out across our entire organization with the Mind the Gap initiative. And with that, I'm going to hand it over to Dr. Baker to talk about what's happened for us in 2020.
Thank you, Dr. Giambroni. So I'm a little worried about my audio. Can you hear me?
Yes.
Oh, yay. Okay. Thank you. So I'm here to share with you, and if you can go to the next slide. Again, I mostly wanted to share, and thank you again, Cindy, for just highlighting all the important work that was done and the great improvements that we saw. I really wanted to share my personal perspective on what happened when COVID hit with our great intentions of rolling out the hypertension pilot, really honestly from a personal perspective. So when COVID hit and we were, seeing all of the news like you all were watching, and again, keep this in mind, this is a frontline PCP perspective, and I'm not even taking away from the incredible people working in emergency rooms and ICUs and all of those doctors and nurses and staff that are out there truly on the front line. We're, again, still in outpatient care, but there was an intense amount of fear at the primary care offices with all of the physicians and all of the staff. I mean, we were just expecting all of these incredibly sick, contagious patients to come in and see us, and and it was shocking, and it was scary, and it was learning what PPE was and how to put it on, because it wasn't something that we did in the outpatient setting very often. And we were expecting all these patients to, flood in so sick, and what were we going to do with them? And then to our complete shock, no patients came. The patients were absolutely petrified of coming in to seek medical care. And so our visit volume declined 80%. We had an 80% reduction in primary care visits in March and April. We still continue to see those sustained reduced visits, but But, you know, we at my office ended up, you know, having these like exercises where we were doing lunges and circle around the office because I went from seeing over 20 patients a day to 3. So, but it doesn't take away from, again, the stressful feeling. And when you're stressed as a doctor and when you're stressed as a staff member, you go into this fight or flight mode that is like, you're just going to do what you need to do. That's all the basics. So when you had a brand new workflow that was just introduced about how we were going to do a great job controlling blood pressure, it completely fell apart. I mean, we had just started rolling out the workflow and working with the teams and doing these WebExes and all of this. And so it was new. And when there's something that's new, and then you add on a stressful event like COVID, it did not get sustained at all. And in addition to that, you know, a lot of the workflow, if you heard, was about the staff taking proper blood pressure and nurse visit rechecks in 2 weeks. And our staff was getting furloughed because our visit volumes were down, offices were closing, offices were getting consolidated. There was absolutely on nobody's mind how we were going to implement this new workflow. So it really, really did truly fall apart. Now, one of the great things, and I heard some of the other speakers talk about it, was the rapid deployment of the virtual visits. And we went from, I had never done a virtual visit in my life, to 45% of our visits being virtual. And it was amazing that we were able to connect with our patients that way. But unfortunately, we had not built any kind of blood pressure capture in virtual visits in our workflow. So yet another reason that, you know, patients weren't coming in the office, staff and physicians were not sustaining a brand new implemented workflow. And then the visit types that we were having, which was almost half of our visits, we had never addressed it. So sort of the outcome of all of this was that we had, you know, year-over-year reductions when you look at our performance this year compared to last year, despite all the efforts and the standard work that was created and the great traction that this program had. We've seen marked declines in our blood pressure control rates. And I think not only for the factors that I outlined in terms of physicians and staff and, you know, implementation science, but also the patients themselves. I don't know that they're exactly focused on their blood pressure control when they have their own worries about, you know, COVID, their kids, their jobs, and all of that. So, anyway, COVID has had a major impact on our ability to achieve success in this. We're not giving up, and we have some next steps in mind. But I really just wanted to share with you again that perspective as a primary care doctor about the impact that COVID has had on a program like this that had so much potential. So thank you.
Next slide. Thank you, Dr. Baker. So I think what we learned, so prior to COVID, I think we had some really good success with the things that we learned by attending that specific Right Care initiative where Dr. Flinn and Dr. Handler presented back in January 2019. And that's one of the real benefits of being a participant in the Right Care initiative, is to be able to network and to hear from those who are successful and how you can apply it within your own organization. And specifically as it relates to the Mind the Gap initiative, the concept of keeping clinical messaging simple and actionable, small changes making significant impact, the importance of accurately measuring blood pressure sounds so simple, but was really a message that resonated with both our physicians and our support staff, as well as the concept of clinical inertia. And then really engagement and involvement of all the key stakeholders to make it successful. And next, please. So what are some next steps that we're doing? So Dr. Flinn, hopefully is still on the line. Dr. Flinn and I are working to put together a Right Care Initiative best practice toolkit. We have kicked it off, and the two major areas of focus for this toolkit will be hypertension and diabetes. And with that, Dr. Flinn, did you want to make some remarks about our project?
Hey, Cindy, thanks for that. Yes, I think the goal of this is to take those lessons learned from what Cindy and Maria described, what they got from Kaiser and from the part about taking accurate BP, where they got the red poster from, et cetera, and make it into a simple toolkit that can be easily distributed and something that can be scaled. So as we talk about, you know, we're taking this statewide and perhaps national, as Hattie is thinking about, what is something practical that can be a nice thing to be able to enable folks to really improve their blood pressure control with their patients. We call them members of the health plan. Our members, your patients, so we can get this blood pressure under control and prevent those strokes and heart attacks, which is what it really is all about.
Thank you, Dr. Flinn. And with that, Hattie, I think Dr. Baker and I will be happy to address any questions.
Okay.
Go ahead, Ed.
So again, thank you, Cindy and Marnie, for a great presentation. I'm particularly interested in the beginning of your improvement, where you look at your data and identified the segment of physicians who contributed most to the care gaps. So I would love to kind of hear a little bit more about how you target those physicians and how you engage them, when I believe many physicians have a lot of initiatives on their plates, and how do you convince them that this is something you want to take on, of course, pre-COVID. And any tips you have in terms of that approach in getting engagement and driving culture change. So I look forward to your wisdom in that space.
Okay, and Dr. Baker, I'll start with the answer and then I'll call on you if I miss anything. Does that sound good?
That's good.
Okay, great. So really, I think the key to success in any change when it relates to quality is having the data. I have been at Memorial Care for 3 years now, and I am so fortunate to work at an organization that has such great data warehousing capabilities to be able to look at quality measures. And it's not quality, it's not just quality. Because of our data warehousing capabilities, is to be able to drill down, to look at who's driving your data, and then be able to share that back. Just like Dr. Handler said, when we went to go listen to him. So leverage your data warehouse and then provide clinic level feedback to individual physicians in order to show them what we're seeing. And so I think just the knowledge of, you know, where individual physicians, how they're performing with specific quality measures, and having that feedback is very impactful, particularly in the context of a clinic site or an overall average. So I don't know, Dr. Baker, if you'd like to share anything additionally.
No, I mean, I think you sort of said, but I'll just say it in a different way, that our data at Memorial Care is very transparent, and physicians are used to seeing their own scores, but they also see their scores in relation to other people. And this is something that they get regularly in performance reports. and doctors are competitive and they don't like it when they're not doing well. And so having that culture of transparency helps when you want to, you know, help somebody improve. And that's the other thing, is it's more data for learning and not for judgment. So doctors are approached with a, you know, not why aren't you doing a great job, but, you know, we'd love to help you see your scores improve, and we have developed something to help you do that. Are you interested? Can we help you? And so just, again, the culture of transparency and also the way that it's presented. It also really helped, I think, to have physician champions, because information was not coming from necessarily, you know, executives or leadership, oh, we need to do better in this quality measure, but really from physicians that were passionate. And I think that makes a difference when physicians actually are endorsing it, and when you're getting the buy-in from the people on the front line. And then the last thing is, I hope I don't say it wrong, Cindy, but some of the doctors in the gap were not necessarily in the gap because their performance was that much lower than other physicians, but they just had that many patients. And so really, when you went to them and said, and showed them their numbers, it wasn't like they felt terrible that their actual blood pressure control was so terrible, but they had such a huge panel that it really did contribute to that gap. And so offering them again in the sense that we want to help you be successful, I thought was another key aspect.
Thank you.
Other questions from the group? I mean, it's been a fabulous hearing the story. So,
well, if others don't have a question, are there? So I would just like to say that I'm really excited about this news about the Right Care Initiative's Best Practices Toolkit that Blue Shield, Scott, and Memorial Care, Cindy Jambroni, are putting together. That's really awesome. Thank you. Can you elaborate on distribution strategy? Because, I mean, we could really become the nation's leader in hypertension control, and that is my dream, as you know.
Well, the notional idea is that we'll put a framework together and then vet it through, obviously, the other folks that are involved in Right Care and the different chapters, to see if we can get some consensus for that, and again, a nice toolkit. And then, Hattie, the distribution, I believe, will be up to you and the team to see how you best want to promote something like that.
Okay.
Well, I'm just thrilled that you have the bandwidth, both, you know, long-term Right Care heroes, Cindy Jambroni, Scott Flinn. I mean, these are superheroes, truly, to take on creating a toolkit. I've always wanted to do it. And I have to say, you know, Bill Baumer and the California Department of Public Health have been working with us to create the hypertension pocket cards that we learned the top performing group in the nation, Gunderson, for hypertension. They use that simple old-fashioned hypertension pocket card. We just had a couple thousand printed. I shouldn't say we, but Bill Baumer led the creation of the updated pocket card. But it's really complicated how to distribute during COVID-19. The state printed them for us, 2,000 copies of them. So maybe we can have some dialogue about how best to distribute them. We do have the California Department of Public Health on the line with us now. And with that, I'll just listen for your thoughts. I hear someone walking on a treadmill, and it's, I think that's wonderful for your health that you're walking on a treadmill, but just muting background noise is much appreciated.
Well, while we wait for the public health to give input on that, I do have another question for Cindy and Dr. Baker, if I may. I'm very curious now that in the COVID world, where telemedicine becomes a more common avenue for people to be seen, and as those of us who are in the weeds of data measurement, there is a provision now that patient-reported blood pressures, patient self-monitored blood pressures can count for the quality
Honey, can you
measure.
hand me my blood pressure bag over there?
And we at PAMP is developing some workflows during the pre-visit, the virtual rooming portions of that to try to capture that. It's still clunky, but I wondered from my Memorial Care colleagues, have you, in light of the virtual visits, what is your approach to capturing patient reported or basically witnessed blood pressure checks at the home by the patient, and any wisdom that you have in that workflow will be greatly appreciated. Thank you.
Dr. Baker, you want to share what you've done on the medical group side?
Sure. And sorry, I had to go out into patient care area. So that was me walking with my mask on, but I'm back in my office now, so I apologize. So we had actually worked on, we actually planned on sort of a phase where we were going to even look into sending patients home with blood pressure monitors and figuring out how to capture those remote blood pressures. We did get language from NCQA about what documentation was needed to capture those remote blood pressures, and we had done some implementation of that and some changes in our EMRs so that we could accurately capture the virtual visit blood pressures. But with the HEDIS update that just happened, and the fact that self-reported blood pressures from patients are actually now not an exclusion in the measure, we actually have to embark on an entirely new path because we're going to have a much greater ability to capture patient blood pressures because they can be self-reported from the patient. And so this is a huge change in a measure specification, and we really just learned about it in the last few weeks. So some of our project plan that we had about, again, integrating remote blood pressure monitors directly with our EMRs, we may not actually pursue those avenues anymore because we can just have the patients email us what their blood pressure is, and we're going to be able to capture it. So we're really excited that we feel like a lot of barriers have been removed by this exclusion not being existent anymore in the specification, and excited now to figure out how we can capture patient blood pressures from virtual visits, telephone visits, patient portal visits, and everything. So I hope that answered your question.
Yes, thank you. We're embarking the same journey here at PAMP, yeah. So it's good to know that we're in it together.
Yes.
I just want to say that we did hear a wonderful presentation by Health Partners Minnesota about how telehealth can be used very successfully. It was their work was first published in JAMA in July 3rd, 2013, about how they created collaborative orders for a pharmacist to be working with the patient directly on titrating up their medications to get their control rates improved. And we were just so just thrilled this May when they presented to us from Minnesota about how they have continued to have success. And their approach is they use a blood pressure cuff. I'm trying to show you mine. I'm not so good at it. I don't know how to get it to show, but
there you go.
This has been a godsend. This has been a godsend to me for really biofeedback for me. And actually it was the executive director of the California Chronic Care Coalition. When she heard my story, she gave me this for Christmas. And it's one of my best friends is this blood pressure cuff. I've never had hypertension, but when my numbers were edging up, I took action and lowered my stress, increased my sleep, increased my exercise, and did a more Blue Zones vegetarian Mediterranean diet, lost weight, and my blood pressure numbers are perfect. But as if you don't know your numbers, you don't know you have a problem. But I'm just very grateful for the silver lining of the pandemic, which is that we're all learning to do telehealth. And I have loved my telehealth visits with the Palo Alto Medical Foundation. Dr. Yu, your doctors are amazing. And it's been wonderful to reconnect with your former medical director, who's been my very favorite internal medicine doctor since college, when I first started on the Right Care mission, really, when I was diagnosed with pneumonia repeatedly up at UC Davis when I was a pre-med there, and my sister was working at Stanford, and your former medical director, Dr. Byrne, was the chief resident there. And when UC Davis school clinics kept diagnosing me with pneumonia, my sister said, "Come on down here to Stanford. I'm going to get you seen by somebody who can figure out what's going on." He had me diagnosed with asthma and on the proper medications within 10 minutes, and it really changed my life. So it's just a joy to be able to think of telemedicine as a quality improvement approach, where I no longer have to see a doctor that I don't think is as tuned into my lung issues, because I can use telemedicine to reach, my very best provider. So I think that's the silver lining. And I just have to say, I should invite you all to join us for our next session, which has been arranged by Dr. Bill Baumer from UC Davis, super cardiologist, who of course has this huge national network. He has a relationship with Mayo Clinic, and he's bringing in one of the world's experts on a condition called cardiac amyloidosis. And we'll all be learning a vast amount on Monday, October 12th from 12 to 2:30. We're also going to have our co-founder of our technical expert group and original principal investigator of our National Heart, Lung, and Blood Institute grant that started our first pilot. Dr. Robert Kaplan went off to the National Institutes of Health and the Agency for Healthcare Research and Quality in very senior positions, and now has come back to Stanford to be at the Clinical Excellence Research Center. He's going to be talking about the complexity that we're up against with vaccine strategy. There's a lot of resistance to taking the vaccine. And then I just want to flag for you two very special programs, which I don't have slides on, but I'll just tell you that on November 9th, we are going to hear from the head of the heart division of the National Heart, Lung, and Blood Institute. And then on November 24th, in our Bay Area, Silicon Valley chapter, we're going to have a very special stroke program that we're going to be doing jointly with the California Department of Public Health and Chuck Tennisketter, the Stroke Survivors Group, the Stroke Awareness Foundation. So that'll be our special emphasis stroke day on Thanksgiving week Tuesday at the same time slot, 4 to 6. We're also going to do a champagne toast to Betsy Thompson that day for a very special announcement that she will be making. And with that, I would like to hand the mic back to Dr. Bill Baumer, the chairman of our statewide chairman of the University.
Well, thank you, Hattie, and I would certainly like to thank our presenters today for an excellent review of everything. It certainly goes a long way to advancing our approach to the disease that we are all trying to eliminate, and that's diseases associated with cardiovascular death and premature death at that time, complicated today by COVID as we go on. And I think as as our presenters have been able to show, having an organization, having to sit down, decide how we can to adapt to this and be flexible, setting up a program. And I really like Scott's proposal for a toolkit. I think that we have a lot of partners in California to work with, and not only those within Right Care, but the California Department of Public Health, I'm sure would be very willing to help facilitate distributing that around. And I think it's very helpful because what I really liked was your red chart there for measuring blood pressure. And I think it really rings true to us that so many different things affect blood pressure. And I have patients all the time who say, hey, my blood pressure was up here or down this, what's going on? It doesn't make sense. Well, it does make sense that there are a number of variables, and I liked your graphic there of the 8 to 10 things that affect blood pressure and by how much. And that gives us a clue as how we can make better measurements for that. And additionally, in the toolkit should be the toolkit to show that additional things of lowering blood pressure that are literally lifestyle, including losing weight, potassium in your diet, more exercise. And it goes through how many millimeters you drop your blood pressure with each of those, and a composite of all of those, combining those, can literally drop your blood pressure 10 or 15 millimeters and possibly avoid medication in that case, which is always very attractive to patients. So I think we've gone through a great 2-hour program here. We want to wrap it up because some of you may be interested in national aspects of healthcare, which are probably about to start right now. And hopefully all of you can stay safe from the fires of California and not have any individuals affected by it. And hopefully all of you and all of us can stay safe from coronavirus and SARS-CoV-2. I think this is an important aspect to discuss. Realize that this is not our first rodeo. This is not our first fire for California, so we'll have to be flexible in adjusting to it. And because we've named this SARS-CoV-2, we have to really sit down and take a lesson from what we've learned so far so that we can, as Terry said, do a much better job when SARS-CoV-3 comes around, because I guarantee SARS-CoV-3 is out there right now in some population, and it's a matter of time before it gets strong enough or flexible enough to get into our population. So thank you very much. Right Care is the appropriate tool to do this. It's the education. It follows it up with the data and the evaluation review so that teams can improve their performance. And that's, again, our ultimate goal, as Hattie had originally. We want to take those over 100,000 deaths in California this past year and drive that as close as we can to zero. That is the mission, and we will not be totally happy until we get in that area. So thank you very much for everyone. Hattie's got a lot of great programs coming along, and we look forward to seeing you on our next programs.
Thank you.
Thank you to our speakers. That was spectacular. Thank you. Thank you to our superhero leaders.
Have a good evening. Bye-bye.
Take care. Don't let your guard down. Thanks, Scott.
Bye-bye.
Bye.